Doing?
Good, how are you? Good.
Realize I have a lot of study for this.
Yes.
Forms, like, state of Maine says
You have to ask the registrar. Email the registrar. It's just email registrar's office. I mean, I guess I'll sign this. Is it like everybody signs?
Yeah.
We just got this far and left. Didn't get to vitamins at all.
You said fuck it. I want some gummies.
John, did you have lunch?
Yeah, that's what I'm thinking about.
Did you go to Browns? I was just thinking after. Yeah, once I get the. Huh? What? I had it.
What? You okay? It was me in the middle, or we'll just all the way in the seat. Did you pick up two?
Oh gosh, gotta go.
Yeah. Yeah, no. Oh, right.
Mike would never.
Come on,
Is there a time?
Thank you. Oh! Good job. Wow. I like that they're taking pictures.
Okay. All right.
Sweetie, what do you have some words? Cancer. Yeah. Can I have this extra? Where are you going?
My phone is like charged. I had Sarah has.
I recommend long-term. What? Emily. I recommend long-term use of
Now I feel like I'm just gonna or something. It's probably a good thing that I'm not connected to the internet.
That was too much.
I'm about to have a great. Yeah, because I think he's living by himself.
Yeah, I know it might. I would. You know, yeah.
Struggling.
Just keep talking when I'm trying to like. We're just trying to leave them all out.
Exactly.
We need to focus when people are talking.
Exactly.
Yeah. Thank God yesterday, the wait.
I hate the waiting game.
Someone asked me for a side, and then my neighbor was
Like, what's that?
what's going on? Like, these two girls are
Oh, you did? Not me. What happened? Oh, that's on camera.
I think I'm gonna set up this back
When
my girlfriend's place. Yeah, very bad. They're in the
I realized that, like, I don't know, randomly on, like, the fifth floor, I'm like,
It's like I signed up for the wrong program. Wrong profession.
that was the oldest. All my name.
The same.
I think I was. I never usually.
Are they good?
They were really great. Like kids.
Cheeks?
I have that chubby. I have really bad.
That guy.
They were like.
With that guy.
I really bad. Like Nicole's child. I said I'm gonna eat something weird. Yeah, he was
Sarah, my friends, because
and
he was
he told
helping
him
me
that
out.
he's like a few him. I'm like, what?
He was like, I remember because he was helping me out on something. He was helping me out with like tests or something like that. So like,
And then he gives me in return. Oh, did you get that one?
no, I had it in. Yes.
I can't
That was weird.
I can't apply.
Like, remember our thing that we said that you were interested in somebody else?
No.
Like, have this
That's like
plan.
Jamari like Alfie could talk. Well, Jamari was had. Oh, you said now.
Like a big help.
Yeah, I'm just.
Hey, no.
Yeah, because I'm fine.
Way more than we do.
Yeah. Remember that?
Not to do at all. No, you're so close.
He was like, Santa has his soul. Soul.
So,
Nicole has like
no, they
no,
can't.
but it's so
No, she was so okay. It's so
I've been rejected
now that I
so many
look back
things.
at
What does he do now? For me. Probably. I will say
you did have banana for like one of the
Are you guys? You got the Okay. Oh yeah, but oh my god. I know. No, but my company does it like the nicest way. So I think it also
Vanguard.
I might have cold her. No. I don't know what you're It's very bad.
It was awesome. Like it was all ladies, but I was like the only guy.
They love you.
Hello. You doing the 1 o'clock too?
Right.
Yeah, I was I think anniversary. I sent it to you. So she found out. She's like, in her face. They look so good.
Especially since I'm
Daniel.
That's mine. Oh, it's our favorite. I know. I'm like 15.
What is it?
Like literally the last time I saw it. First. Like so long ago. Like so long ago.
Yeah.
No, I just
Oh,
went
yeah,
downstairs
she's
to
getting engaged.
bring him the
Yeah, she got engaged.
In December.
People planning it while in residence.
I
Nice. That's perfect.
yeah, look.
Right.
In my
Nice.
But it was oh,
Wait, no. Like it's coming fall, right?
yeah.
Okay. You're so crazy. Yeah, exactly.
Oh, guys. Is that when the
Yeah. Not bad. I would say. Good class.
So you do the entire afternoon session?
No, they say
Okay, so there'll be some. Oh, at 2 o'clock, somebody else will be here? Okay. All right, so it's all sent to you to take over.
아, 그래? 그 여자가 시작부터 금방 했던 여자애.
아, 민지?
너 언제 이사 가니?
6월 초.
왜 책을 만들었네?
아 나도 잘랐거든 책을. 너무 많아서. 근데 이게 지금 1000몇 개잖아? 아니.
한 3개로 나왔어.
아, 너 3개가 많았구나. 나는 이제 잘라서 이거 얼마나
그 원비가 내일
나는 2부 잘라서 Megan, this is a good idea. I don't know. There's all kinds of water.
just
You got 3 of How much it cost you? 3 hours for each?
everything all
What do you call this? Right?
so you just asked him, can you
You're gonna give this thing to me special.
yeah, you can ask it. 로봇 샴푸는 내가 가려야 되는데
I love your idea.
Tell them you just make a copy of the cover sheet and they're gonna ask if you want neat or flat. It takes about 1 day.
Well, I haven't been using my book every day, so no problem. No, because when I cut my book, it was only $2 to cut it out. Yeah. They couldn't cut it in one, so they charged it.
You have to go to
Yeah, I know. It's called a price.
That's awesome. Molly, are you leaving now?
6월 26일에 다음 주에 대학교 부모님이랑 캔자스 가서 아파트 보고 캔자스 스테이트 미즈리인데 그리고 나 지도 보면은 캔자스랑 미즈리 옆에 딱 정중간에 이렇게 디바이드 라인 있지 거기에 캔자스 시티가 있어 그래서 캔자스 난 미조리 왜냐면 병원 자체가 캔자스가 근데 나도 그냥
내 책이를 그렸어?
이거 안
보내는 거 하고
그거는 아직 안 했어.
1000까지 보내라고.
아 그거는 이제 그 그레듀에이션 때 그건 했는데 나 소리로 아직 안.
All right, guys, we'll get started. See how much we can get covered. It's 120 slides, so got going here.
힘들겠다. long distance인데.
Manchester, I think we're gonna get started. For anybody who wants to listen in. Thanks so much. All right, guys. So asthma and COPD.
지금 없어.
We can do. All right, so we're going to jump right into asthma. So what is asthma? It's an airway inflammation that contributes to airway hyperresponsiveness, airflow limitation, respiratory symptoms, and disease chronicity. Characterized by variable and reoccurring symptoms, airflow obstruction, bronchial hyperresponsiveness, as well as underlying inflammation. So asthma, inflammation, inflammation, inflammation. Just think of that. There we go. All right, so it is a chronic inflammatory disorder, and it is responsive to triggers, which are different patient by patient. There is some cellular involvement, which will help you kind of learn the pathogenesis of the disease. So that's mast cells, eosinophils, neutrophils, especially in sudden onset exacerbations, occupational asthma, and smokers. T lymphocytes, macrophages, as well as epithelial cells all play a role. This results in recurrent coughing, particularly at night. So asthma awakening is a key symptom that we assess when we're assessing severity and if asthma is well controlled or not, as well as breathlessness, wheezing, and chest tightness. And asthma is reversible, so that is a key difference from COPD. So either with treatment or sometimes exacerbations will reverse spontaneously, but that is key when differentiating between COPD and asthma, as well as the cellular involvement. And this is just for like the visual learners here, a little depiction of asthma and its process and how it relates to symptoms. But again, inflammation. Some risk factors are innate immunity. Hygiene hypothesis, does anyone know what that is? So it's kind of the medical theory that if you weren't exposed to a lot of pathogens as a young child and you didn't get sick, it actually hurts you because it didn't require that your immune system fully matured. So that way that you are susceptible to these allergies and you're hypersensitive to allergens in the environment. And this is why you could possibly have asthma. It's a theory on a couple allergy-based. Some host factors, just genetics, predisposition, as well as environmental factors. So airborne allergens, people that live in inner cities, as well as viral respiratory infections. All right, so some presenting symptoms, wheezing. So high-pitched whistling sound. This is particularly noticeable in young children, but absence does not rule it out. Some people have it, some people don't. As well as history of a cough. We mentioned that it was worse at night in particular. So the recurrent wheeze, as well as difficulty breathing and chest tightness. Symptoms occur to worsen in the presence of exercise. So EIB, exercise-induced bronchospasm. You'll hear that quite often. Viral infection, inhalant allergens and irritants, changes in the weather, the season. Strong emotional expression, stress, and even change in menstrual cycles, as well as symptoms occur or worsen at night, awakening the patient. So again, that's a symptom of a consideration for severity. All right, so diagnosis. Episodic symptoms of airflow obstruction or hyperresponsiveness are present. So reviewing their medical history and past physical exam. And airflow obstruction is at least partially reversible, measured by spirometry. So this is for patients greater than 5 years old, because obviously in patients 0 to 4, we're not going to be able to test them via peak flow meter, right? So reversibility is determined by an increase in FEV1 of greater than 200 milliliters or greater than or equal to 12% from baseline after inhalation of a short-acting beta agonist. So was there a significant change from baseline there? And alternative diagnoses are excluded. So have you kind of looked at the differential and excluded everything else, such as like an upper respiratory infection? All right, so some goals of therapy. We want to reduce impairment, so prevent chronic and troublesome symptoms. Require infrequent use, so less than 2 days a week of that SABA. Don't want them using that all the time. We'll get into that later. And maintain normal pulmonary function, as well as activity levels. And meet also the patient's and the family's expectation and satisfaction with care, so developing that goal plan. Reduce risk, so we want to prevent recurrent exacerbations of asthma and minimize the need for ED visits or hospitalizations, because as we all know, those get to be pretty expensive. Prevent the loss of lung function, especially for children, and we want to prevent reduced lung growth. We also want to provide optimal pharmacotherapy with minimal or no adverse effects. All right, so this is just looking kind of at the early process of asthma. So at first we have the allergen, and in yellow is where potential treatment options would act. So avoiding the allergen, step 1. 2, the allergen binds to IgE on mast cells. And 3, the mast cells degranulate, or they release those cytotoxic materials. That's where mast cell stabilizers act. And then these mast cells also excrete inflammatory mediators and chemokines. It's where the LTRAs act. And then 4 is bronchoconstriction, where you have your beta agonists and your anticholinergic agents. All right, so management of asthma. Treatment recommendations are provided for 3 different age groups. So we have the 0 to 4, like I mentioned, 5 to 11, and then everybody else greater than 12 years old and adults. All right, so looking at our first charts. So if you remember asthma, I just think charts, because those are pretty key. I know it looks like a lot of information too, but it's pretty similar between age groups. I recommend for studying, printing out each age group. We'll go through them now, but printing out each age group the chart and kind of noticing the differences between them and seeing, okay, this drug's only used in adults and this drug is used in adolescents, and that way kind of differentiating, because it is a lot of information here. But this is classifying the severity and initiating therapy for children. So we have 2 age groups on here, both the 0 to 4 and the 5 to 11. So severity is based on 2 components, so impairments as well as exacerbation risk. Impairments based on symptoms, so how many days of the week, as well as nighttime awakening, so we mentioned that earlier. SAB use, interference with normal activity, as well as lung function, so those actual numeric tests, the FEV1 and the FEV1 over FVC. And then the bottom here is initiating therapy, so which step to initiate on based on if the child has intermittent asthma or persistent asthma. And if persistent asthma, what category is it? Mild, moderate, or severe? All right, so this is the first treatment chart we'll actually look at. So this is 0 to 4. So yeah, definitely print this out and review it, because I did have a bunch of asthma on my Naplex. But I did hear that it's usually pretty much, it's definitely going to be, at least one question is going to be on there. So look at this. This one you'll notice is pretty bare, just because it is 0 to 4. Not a lot of drugs are indicated in this population. Not too many options. And then if the asthma is well controlled for about 3 months, consider a step down. So it's not always a step up, but you're looking at that step down as well. This is 5 to 11, so if you notice some changes in here, now we have theophylline in there. I think that's the only change from here. But again, going for that initial therapy chart and comparing it with this treatment chart. This treatment chart also aligns with the reassessment chart, which we'll get to. All right, so this is assessing control and adjusting therapy. So this, again, is based into 2 components, so both impairment and risk. It's a little more detailed than the initial, a little more complex than the initial therapy chart. And if we're assessing if the patient is well controlled, not well controlled, or very poorly controlled. So again, looking at symptoms, nighttime awakenings, interference with activity, SAB use, lung function, but also looking at past exacerbations requiring corticosteroids, reduction in lung growth, especially in children. It's something that we're looking at, as well as treatment adverse effects. So what have we tried? What have we haven't? Something to consider. And this should be reassessed about 2 to 6 weeks after initiation of therapy, depending on initial asthma severity. You want to follow up. That follow-up process pretty quickly, especially in children. This is just another chart for you guys. This one has all the everything on one chart. So at the top there is the children 0 to 4, and at the bottom is 5 to 11. It's a little less detailed than the previous charts, but it is a nice overview, kind of a nice one-pager with the same info on it. All right, so this one is the adult classification of initial therapy. So we're going to classify severity as well as recommend a step treatment. So again, in pretty much same qualifications, divided into impairment and risk. So looking at symptoms, nighttime awakening, SAB use, lung function, all that good stuff, as well as the risk of exacerbations and initiating a therapy based on steps. The step therapy also is kind of not a rule for providers. You'll see a lot of differentiations from if a provider wants a patient to be on, so wants to start them, on, they should be started on a step 2, and the provider wants to start them on a step 3. It's more of a guideline. I have had providers say that, with my personal experience, I think this works better. And it's, sometimes providers they're specialists and they do what they want to do. So it's not a full-on, you'll see a lot of variation, but it is good. good basis. All right, all right, so this is when we're going to assess in 2 to 6 weeks. Again, that window after we initiate therapy, we want to assess control. So again, same, are well controlled, not well controlled, or are they very poorly controlled and need a super change to therapy? And then if they are well controlled, we want to consider, can we step down? So I feel like that never really happens, and that should happen more where we're looking at a patient that is on medications that they have been well controlled for months, and do they really need to keep taking this? So if they're well controlled for at least 3 months, we'll look to step down, not always to step up. All right, so the only thing different here is that they do use validated questionnaires into this system, as well as looking for, again, treatment-related adverse effects. All right, and here is the chart treatment for adults. So if you look at what's different between this versus the children-related charts, we have theophylline on here, the LTRAs are on here, alemtuzumab is on here, or Xolair, if anybody has ever seen that drug before. It is a sub-Q injection given every 4 weeks. I actually have a patient in my pharmacy who's on it right now. And then also Xeluton is only indicated for adults as well. All right, so drugs used in the treatment of asthma. So this is just kind of breaking it down. So asthma causes inflammation and tissue remodeling. Tissue remodeling thus induces bronchial hyperresponsiveness. This is easily triggered bronchospasm. So therefore, we have anti-inflammatory drugs as well as bronchodilators. So going into step 1, we have the short-acting beta agonist, the SABAs. So the mechanism of action here is that it binds to beta receptors in the lung on several sites in the muscle cell membrane. The end result is smooth muscle relaxation and bronchodilation. Onset is approximately about 5 minutes, so these are your rescue inhalers. Some adverse events are dose dependent, so that's why we always watch how much that patient is using their SABA inhaler, because the more that they're using it, the more likely they are to experience these adverse effects, right? So it's heart palpitations, anxiety, tachycardia, tremors most common, as well as hypokalemia and hypomagnesia is possible with enough use. So think of those beta, the drugs that we use for hypertension. It's kind of the same side effects with those high doses of the SABA, acting on the same receptors there. And so again, using SABA greater than 2 days a week indicates that we need to increase, either step up or begin, if they're not already on long-term control medications, begin those. They do not have intermittent asthma anymore. All right, here's a chart here of some SABAs. So most common ones being albuterol and levoalbuterol, or ProAir, Ventolin, Proventil, or Xopenex. And then their dosage forms are available on the side there too. Dosing is for you here, guys. So for adults with the HFA, 2 puffs every 4 to 6 hours as needed for symptoms. Or 2 puffs 5 minutes before exercise if they have that EIB, that exercise-induced bronchospasm. All right, and this is, everybody seen this? Bronchade, Primidine. So those are short-acting bronchodilator anticholinergics, not really preferred. Atrovent is ipratropium. It should be given to patients that's at least 12 years old. The MDI dosing is 2 puffs every 6 hours, while the nebulizer is every 6 hours as well, at 0.5 milligrams. All right, moving on to the anticholinergics. Mechanism of action here inhibits cholinergic and muscarinic receptors on bronchial smooth muscle, causing this bronchodilation. This decreases vagal tone and anti-secretory properties. So again, those anticholinergic side effects all come into play. Onset is a little shorter, about 5 to 15 minutes. Adverse effects include dry mouth and respiratory secretions. So again, the whole anticholinergic bag there, and increased wheezing in some patients, so having that opposite effect as well, but it does have those less cardiac effects than the SABAs. All right, so short-acting bronchodilator combination. So albuterol and ipratropium are available in a combination product. This is the Complement Respimat. So it's one inhale every 6 hours or 4 times a day, max of 6 in the 24 hours. And it's also available as DuoNeb for a nebulizer. You guys may see this if you work in the hospital, especially if they will throw DuoNeb just on just about everybody. And that's 3 mLs every 4 to 6 hours. All right, so step 2 is a low-dose ICS or inhaled corticosteroid. And this is the preferred treatment for step 2 patients. Mechanism of action is to decrease the number and activity of inflammatory cells. It's better at reducing inflammation caused from eosinophils versus neutrophils. So remember how we said those eosinophils are more involved in asthma, where the neutrophils play more of a part in COPD. Enhanced effect of beta-adrenergic drugs. They inhibit bronchoconstriction mechanisms, as well as cause direct smooth muscle relaxation. All right, some adverse effect of inhaled corticosteroids. So cough is a big one. Dysphonia is most common, so trouble with voice. Oral thrush if the patient doesn't rinse mouth after use, so that's something to counsel the patient on for sure. In high doses, it can cause all those side effects that oral corticosteroids cause, so adrenal suppression, osteoporosis, skin thinning, easy bruising, cataracts, as well as growth suppression and retardation. So especially in children, if they have really severe asthma and they're on these super high inhaled corticosteroids, a lot of times their growth is stunted and they will not grow to their full height as an adult because of their severe asthma as a young child. Low to medium dosing, so growth velocity in children may be altered, resulting in possible growth suppression of about 1 to 2 centimeters total through adulthood. That's in low and medium dosing. In higher doses, that gets more severe. All right, just a table for you here. I won't go through these all. I would say one probably couple to know would be QVARs. I see a lot. Asmanex is a common one. As well as the budesonide. So know that there's a Respimat, there's a Respules and the Flexhaler formulation. All right, these are low doses ICS. It's a lot. And some alternative agents for step 2. So we talked a little bit about these, the mast cell stabilizers. So these will prevent mast cells from excreting those materials. So cromolyn. And netochromol. Those are currently, the brand names are discontinued in the U.S. Cromolyn, generic, is still available. And the leukotriene receptor agonist. So that's Montelukast, which is singular, and then acrylate, which is Zarficlulast. I think that one's, sorry, am I saying that right? Zafirculast. Okay, Zafirculast. There we go. Or accolate is how I say it. So go right to accolate. And then theophylline, which theophylline is not the best choice because it requires that serum drug monitoring.
Yeah.
All right, so cromolyn and netochromol, mechanism of action is stabilize mast cells and blockade of chloride channels. May be used as preventative therapy prior to exercise or unavoidable exposure to known allergens. So if a patient does have that EIB, they can take these agents about an hour before exercise to help prevent that. Similar anti-inflammatory properties, excellent safety profile, however, questionable efficacy. All right, so cromolyn comes in an MDI and a nebulizer, dosing for you there. Netochromol is discontinued and some dosing for you there. But once control is achieved, frequency may be reduced. So if the patient is on these medications and they're effective, then we can think of that step down and going down to that step 1. All right, LTRAs, so Montelukast and accolate. So mechanism of action would be to interfere with the pathway of the leukotriene mediators, which are released from mast cells, eosinophils, and basophils. So really focusing on those anti-inflammatory cytokines. and can be used as adjunctive therapy as well with an ICS. It's not preferable, though, to LABAs for patients 12 years and older. So adults that can use LABAs, those are preferred. And may attenuate exercise-induced bronchospasm, like we mentioned. All right, some adverse effects of the LTRAs. No specific adverse effects have been identified, which is amazing. Like I said, they have a wonderful safety profile. So there are been some warnings and post-marketing surveillance and cases have been reported. So cases of reversible hepatitis, rarely irreversible hepatic failure resulting in death and liver transplantation. It can be known to... can be recommended to monitor liver enzymes, particularly ALT, depression, and suicidal ideation in children taking Singulair, also in adults. Those are all post-marketing. Okay, Xoluton, or Zyflo. Mechanism of action, it is a 5-lipogenoxinase inhibitor. It's similar to the LTRAs, but only blocks the enzyme, not the actual receptor. Elevation of liver enzymes has been reported, so these have to be monitored, particularly ALT. Limited reports of reversible hepatitis and hyperbilirubemia have been reported. Drug interactions, so this inhibits metabolism of warfarin and theophylline, so something definitely to mention. And is not preferred over LTRAs, so this is only identified for use in adults, and if they can use the LTRAs, you definitely use the LTRAs. This is for someone that's not controlled or cannot tolerate an LTRA. All right, so the LTRA dosing chart for you here. Singulair, it's usually 4 milligrams at bedtime for young children. If for 6 and older, you can increase to 5 milligrams at bedtime. And then for adults, 10 milligrams at bedtime. And those, for children, it's also available in a chewable tablet as well. For Zafirlukast, it is 10 milligrams twice daily, indicated for children 7 to 11, and then 20 milligrams twice daily for the full adult dose. And Xoluton is actually 600 milligrams 4 times daily, and that is the maximum dose, so usually that's a titration up. All right, there's some Zafirlukast. It does have some food interactions. Food does decrease bioavailability. You want to take at least an hour before or 2 hours after meals. And it is a substrate and an inhibitor of CYP2C9. This is why it has that interaction with warfarin. It can increase drug levels. All right, so theophylline. I mentioned it did require drug monitoring. We'll get into it a little bit more here. So mechanism of action, it is a mild to moderate bronchodilator. It is a non-selective PDE or phosphodiesterase inhibitor and may have mild anti-inflammatory effects. So like I said, it must monitor serum concentrations and adjust dose to achieve serum concentration of about 8 to 15 micrograms per milliliter at steady state. That's kind of the window where we want it. There is a sustained release formulation. You want to obtain concentration in the middle of the dosing interval. So at least 3 to 5 days after initiation and at least 48 hours after initiation of any factor known to affect that theophylline clearance. Manchester, do you have a question?
We're good.
Good? Okay, sorry. There is wide interpatient variability because patients do metabolize this drug differently, so that's why different doses will cause different drug levels. So it's really hard to tell. There is a bunch of adverse effects with theophylline. That's why it's, along with the drug monitoring, it's not used very often. Usual dose will cause insomnia, gastric upset, aggregation of ulcer or reflux, hyperactivity in children, as well as difficulty in urination in elderly males who have prostaticism. Toxicities include tachycardia, nausea, vomiting, central nervous system stimulation, SVT, seizures, hematemesis, hyperglycemia, and hypokalemia. Sorry, guys, my allergies are crazy, and I took 1 million Benadryl, so my dry mouth is crazy right now. Anticholinergic effects, right? All right, so some interactions. Theophylline is big on the interactions as well. So you got drug monitoring, you got side effects, and drug interactions. It is metabolized by the CYP system, particularly 1A2 and 3A4. It has increased clearance and decreased levels for smokers. So smoking actually has increased theophylline clearance by 40%, and is not thought to induce CYP1A2. Polycystic achromatic hydrocarbons, not particularly nicotine. Phenytoin, phenobarbital, and rifampin all interact with theophylline as well. Decreased clearance, so increased levels of theophylline. Macrolides, so these drugs will actually decrease clearance of theophylline by 25 to 50%, so rather significantly. So that's erythromycin, clarithromycin. Fluoroquinolones also, Cipro, decreased clearance by the 25 to 50%, and cimetidine. So pretty significant interactions. Theophylline dosing for you here. So it comes in a variety of formulations. There's liquids, there's sustained release tablets, and there's capsules. And there's the doses for you there. I won't go through them. But the max for adults is about 800 milligrams daily, with the typical starting dose of 300 milligrams. All right, so step 3 is ICS and LABAs. This is the preferred treatment, is a medium dose ICS. So it's first choice of the first choices if possible, because we don't want to go too high on that ICS, on the dose of that ICS, because then we get those corticosteroid side effects, right? So the lower the dose of the ICS we can go is great. So the preferred treatment would be a medium dose ICS or a low dose ICS plus a LABA. Alternatives could be a low-dose ICS plus an LTRA, or theophylline or Xoluton if they qualify. A LABA, so we'll go down the mechanism of action here. So the tail binds to the beta receptor at the exosite. This prevents the molecule from dissociating from the receptor. The head attaches to the same spot as the SABAs, but it continually attaches and detaches, which allowing it to be long-acting. This causes bronchodilation. It does not exert any anti-inflammatory action, thus should not be used as monotherapy. So if you see a patient just on a LABA, that's an issue. And they have asthma. All right, so some adverse effects. Tachycardia, tremor, hypokalemia, we've seen those with the LABAs, as well as unexpected bronchiospasms and hyperresponsiveness, just because that molecule is attaching and retaching. And heart has some beta-2 receptors, so you can have some of those cardiac effects, increased pulse and blood pressure, as well as prolongation of the QTc interval in an overdose. All right, LABAs do have a black box warning. It's an increased risk of severe asthma exacerbation and asthma-related death with regular use of LABA. This is based on a study, about 25,000 people that happened in the UK, that found a non-statistical increase in asthma-related death when salmeterol was compared to albuterol. So other large studies have not found these same results, but it was this one big study that caused the FDA to put this black warning on there. Okay, LABAs, this is asthma dosing, so the dosing for LABAs is different in COPD, so just letting you guys know. That is something to note. It's easy to mix up, that's for sure. And in the yellow there, that's the specific dosing for proper control. All right, these are some medium dose ICSs. We had the low dose, now we're at medium. All right, so some combination products. So LABA and ICS. So Advair, we all know, pretty common. Fluticasone and salmeterol. Symbicort, budesonide, and formoterol. Dulera is mometasone and formoterol. And duration of action is typically 12 hours. So pretty much all of these are twice daily. All right, moving on to step 4. So the preferred regimen for step 4 is a medium dose ICS plus LABA. Alternative could be a medium dose ICS plus any one of the LTRA, theophylline, or the Xoluton. Long-acting anticholinergic, such as tiotropium and Spiriva, is also an alternative. So tiotropium, it's a long-acting anticholinergic. Spiriva comes in the brand name Spiriva Respimat. It can be used as an add-on or alternative option at step 4 or 5 for patients greater than or equal to 12 years old, so only adults, not in that those two other populations that we talked about. With a history of exacerbations despite being on an ICE daily, and max effect may take up to 4 to 8 weeks of dosing. All right, step 5 and 6. So step 5, the preferred regimen is high-dose ICS plus a LABA, and you can consider Xolair or omalizumab, especially in patients with allergies. Step 6 preferred, it would be a high-dose LABA. A high-dose ICS plus LABA plus oral corticosteroid, and you could consider omalizumab. Because in step 6, they're most likely having a exacerbation. All right, these are the high-dose regimens. We'll go through all those. All right, so Xolair is recommended in steps 5 or 6 for patients with allergies and severe persistent asthma inadequately controlled on high-dose ICS plus LABA. Since it is a monoclonal antibody, we never really take this lightly, so definitely in your most severe of patients. Approved for patients 12 years and older with proven sensitivity to dust mites, cockroach, cat, or dog, so those specific allergens and those triggers. Mechanism of action, it is a recombinant DNA-derived humanized monoclonal antibody. It is specifically IgE. It binds to the portion of IgE antibody preventing the binding to its high-affinity receptor on mast cells and basophils, so those cells that we first mentioned on the first slide there, those main players in asthma. Leads to a decrease in the release of mediators in response to allergen exposure. Some adverse effects of Xolair is urticardia and anaphylaxis, reported in about 0.1% of cases. Post-marketing surveys have identified anaphylaxis in about 0.2% of cases. Those allergic reactions with monoclonal antibodies are pretty common. It is an FDA alert. Most instances occurred within 2 hours after the injection, after the first 3 injections, but some occurred outside of these time reports. So it's just always something to cancel on at every single refill, since it is a sub-Q injection. Injection site pain and bruising, up to 20% of patients have patients rotate injection sites. Malignancies, so Xolair patients were twice as likely versus placebo in study, with no trends towards a specific tumor. So I mentioned it's a sub-Q injection. It's 150 milligrams per 1.2 mLs following reconstitution. It's only approved for patients greater than 12 years old. And it's about 150 to 375 milligrams every 2 to 4 weeks. It depends on body weight and your pre-treatment IgE level. So if a patient's IgE level is extremely high, then they're likely to get a increased dose. All right, I'm going to be bad with these names. Mepolizumab and Rezlizumab. They are Nucala and Sincair, respectively. Recommended in steps 5 or 6. So again, for the patients your sickest patients here, with eosinophilic phenotype asthma inadequately controlled. So really just targeting those eosinophils. Its mechanism is that it's an interleukin-5 agonist, particularly IgG type. Inhibits interleukin-5 signaling, reducing the production and survival of those eosinophils. Its true mechanism of action in asthma has not been definitively established. All right, so some adverse effects is headache, fatigue, pruritus, UTI, abdominal pain, influenza, back pain, muscle spasms, local injection site reaction, again, pain, swelling, redness, and burning around the injection site. Frequency has not been determined, so hypersensitivity reaction can recur within hours of injection. Also has been reported a herpes zoster opportunistic infection, so consider the shingles vaccine prior to therapy. Dosing on this drug is it's sub-Q injection again, so upper arm or thigh. This is 100 milligrams once every 4 weeks, only approved for patients greater than 12 years old. No geriatric, renal, or hepatic dosing adjustments needed. Okay, so Sincair is recommended, again, in steps 5 or 6 with eosinophilic phenotype asthma inadequately controlled patients. Again, it is a interleukin-5 agonist with IgG1. Inhibits interleukin-5 signaling, again, reducing the production of eosinophils. This also has their true mechanism of action and its kind of place in asthma has not been adequately established. Not quite really sure. Adverse effects is the antibody development. Increased creatine phosphokinase that usually goes away with therapy. So sometimes after the first injection, this will happen, and that will decrease with time, but it does need to be monitored. Myalgia, about 1%. So you can see that in 20%, creatine phosphokinase goes up, but only in about 1% does it actually turn into muscle pains and myalgias. And then orthopharyngeal pain. All right, so anaphylaxis was reported in 0.3% of asthma patients in placebo-controlled studies, observed during or within 20 minutes after completion of the infusion, and may occur as early as the second dose. You want to observe patients for an appropriate period of time after the administration, just to make sure that that allergic reaction does not occur. Malignancies, just like with any monoclonal antibody, patients are at increased risk. So this was observed during clinical trials, with the majority being diagnosed with less than 6 months of drug exposure. Neoplasms observed were diverse with no predominant type, no specific cancer type. It is an IV infusion only, so infuse over a 20 to 50-minute period. 3 mg per kg is every 4 weeks. Only approved for patients 18 years and above, so different from the other monoclonal antibodies that we talked about that were 12 years and older. And then again, no drug adjustments needed. All right, so oral corticosteroids, long-term control. So these are only recommended for the most severe, difficult control asthma due to well-documented risk of side effects, right? We all know that long-term corticosteroids is never ideal for any disease state. Here are a couple of the dosing regimens here. We'll go through them a little bit. So for skipping the children and going right to the adult section. So methylprednisone or the equivalent, 7.5 to 60 milligrams daily in single dose or every other day as needed for control. Short course would be a burst, so that's typically with an exacerbation, about 40 to 60 milligrams daily as a single or given in divided doses for 3 to 10 days. So I'm sure you've seen that at the pharmacy where these high doses, a patient comes in and they're only getting that 5-day course. All right, so oral systemic corticosteroids adverse effects. We talked a little bit about these, but for short-term use, there are different versus long-term use. So in the short term, we have reversible abnormalities in glucose metabolism, usually an increase in glucose, increased appetite, fluid retention, weight gain, mood alteration. Patients will be crying if they're on say a 7-day course of these high corticosteroids. Usually by day 2 or 3, they're crying, kind of don't know what's going on, and that's just because their body really hasn't adjusted to these high dose steroids yet. Hypertension, peptic ulcer, and a rare of aseptic necrosis. Long-term use, you're going to get that adrenal axis suppression because you're supplementing. Your body will not be producing cortisol. Growth suppression, dermal thinning, hypertension, diabetes, Cushing's syndromes, cataracts, muscle weakness, and rare, you're going to get long-term impaired immune function. All right, so drug disease interactions. Systemic corticosteroids can worsen some medical conditions, particularly herpes virus infection, because it does lower the immune system. So with that immunosuppression, the virus can take over, and people can have outbreaks, as well as varicella, tuberculosis, hypertension, PUD, diabetes, and can cause osteoporosis and bone reabsorption. All right, so short-term bursts are effective for establishing control when initiating therapy or during a period of gradual deterioration. For a course less than a week, no taper is really required. For courses greater, so about 7 to 10 days, most likely don't need to taper, especially if they're already on an inhaled corticosteroid. Their body's already used to a level of corticosteroid already being in the body. But for older patients, more than 5 days, and for healthier patients, greater than 3 to 5 days. All right, so non-pharmacological treatment is just as important when counseling a patient. So avoiding those triggers, avoiding those allergens, whether it's smoke or pollutants or dogs or cats, removing carpets, encasing mattresses and pillows, vacuuming, keeping the windows closed. I haven't had my windows in my apartment open all week because I'm dying, and keep having air filters, as well as if in severe cases having allergy-free zones in the house. You You want to discuss goals with the patient as well as with the patient's family, particularly if it's a child. All right, so EIB we talked about a little bit. So this is exercise-induced bronchospasms. First line is going to be the SABAs or the albuterols. Prevention, you can take 2 puffs, 5 to 30 minutes, usually about 15 minutes prior to the exercise, and this will prevent EIB for about 80% of patients. May be helpful for about 2 to 3 hours. And this doesn't count towards those charts. So if a patient says, "Oh, I'm using my SABA, 2 times a week for football practice," that's just if they're using it for the EIB, that won't count towards how we're assessing if their asthma is well controlled or not. And it may be helpful for about 2 to 3 hours. Second line would be the LTRAs. So onset of action is generally hours after administration. So like I said, probably take it an hour to 2 hours before you're going to exercise, and can attenuate EIB in up to about 50% of patients. Last line would be the cromolyn, just because the efficacy data isn't really there. It's taken shortly before exercise as an alternative treatment, but it is not as effective. Non-pharmacologic techniques could be a warm-up period before exercise, or a mask or scarf over the mouth can attenuate cold-induced EIB, especially if you're on a sports team and you're practicing outside in the middle of winter. All right, exacerbations. All right, so classifying severity, just what's a not so bad exacerbation and what's a severe exacerbation. So mild would be signs and symptoms, dyspnea only with activity. So you want to assess this, especially in young children. And assessing the initial PEF or the FEV1. That would be greater than 70%. Clinical course for a mild exacerbation, it's usually cared for at home with the rescue inhaler. Possible short course of corticosteroids, particularly in a child, but sometimes usually doesn't require a trip to the doctor or anything like that. Moderate would be it interferes or limits usual activity. So this is when the PVF is 40 to 69% of a person's usual or the suspected or the predicted PEVF for their age group. Usually requires an office or an ED visit, frequently from SABA. So they're using it multiple times daily. And then this is going to require oral systemic corticosteroids, and symptoms may last about 1 to 2 days even after you start those steroids. Severe, so that is dyspnea at rest. So it's when a patient can't catch their breath even when they're not moving. This interferes with conversation. This is when the PEVF is less than 40% of the patient's baseline or what's predicted. Usually requires a emergency room visit for sure. Partial relief from frequent SABA, you're not even getting that full benefit from the SABA, and oral systemic corticosteroids. And then symptoms could maybe last greater than 3 days after starting that treatment. Adjunctive therapies are usually helpful in this case. And then the subset is your life-threatening exacerbation. So they can't even speak, they're sweating, their PEVF is less than 25% of their baseline, and this requires hospitalization, maybe even the ICU, and you really never want patients to get to that point, and usually requires IV steroids. This is just a little flow graph for you, assessing exacerbations. How are we on time? Perfect. All right, so so this is the inhaled SABA dosing for albuterol with the MDMI or the meter dosing inhaler. Won't go through all these. But asthma and GERD, there is a connection. So patients with asthma, about 75% of them also experience GERD. They're twice as likely to have GERD. Severe chronic form resistant to treatment are most likely to also have GERD. So the sickest asthma patients are most likely to have GERD. Non-pharmacological treatment for these patients should include techniques for GERD as well. GERD can also worsen asthma, so they are linked, and asthma and medications can worsen GERD. Treating GERD often helps to relieve asthma symptoms, so acid flow could be related to injury to the lining of the throat, airways, and lungs, and then this injury causes cough. So acid in the esophagus triggers a nerve reflex, narrowing the airway to prevent acid from entering, which then causes shortness of breath. So there is a link there. All right, this is another flow chart for you. Big on the charts this time. So this is just a summary of basically the components involved in asthma and where the drugs fit. All right, so we'll spend about 10 minutes on COPD and see what we can get through. All right, so COPD is preventable, it's treatable, it is a component of airflow limitation, and it is progressive. All right, when comparing asthma and COPD, because they're easy to get confused. So onset of asthma is usually early in life, often it's in childhood, and COPD is later in life, typically middle-aged. The usual etiology of asthma is immunologic stimuli, family history, like we talked about. COPD, it's cigarette smoke, exposure to other risk factors. So it's more environmental, more lifestyle choices. Asthma, so the course of asthma is usually intermittent. You have exacerbations, you have treatments. Sometimes patients will, if they have asthma as a child, they'll grow out of it as an adult, where COPD is chronic and progressive. Airflow limitation in asthma, like we mentioned, is reversible. Where COPD, it's partially reversible sometimes. Clinical features, asthma, we had that episodic wheeze, chest tightness, dyspnea, and cough, where in COPD we have that chronic cough and that sputum production and persistent or worsening shortness of breath. And the inflammatory mediator, the main player in asthma is the eosinophils, where, as I mentioned earlier, in COPD it's those neutrophils. All right, COPD. So emphysema, it's a pink puffers is another name for it, or barrel chest, some signs. Chronic bronchitis, they call them the blue bloaters, where patients would have a blue coloring to their skin. This is characterized by chronic cough and mucus secretion. All right, so some risk factors. So cigarette smoking being number one, as well as genetic predisposition, occupational dust and chemicals, indoor and outdoor air pollution, as well as respiratory infections. Socioeconomic status has been related, as well as gender. All right, so some classic symptoms of COPD. Hallmark is dyspnea, so shortness of breath. It is a chronic cough. Often the first symptom that is present is the chronic cough. It's intermittent at first, and then it presents to daily. So again, that progressive worsening of disease. Sputum production, chronic bronchitis, like we mentioned, but spirometry is needed to make that confirmation of diagnosis. All right, so this COPD, because it is a progressive disease, it does have stages. Stage 1 is considered mild. This is characterized by spirometry. In stage 1, it has mild airflow limitation. Symptoms of chronic cough and sputum production may be present, but not always. Patients are usually unaware. There's a lot of patients that aren't diagnosed with stage 1 COPD. Moderate COPD, its shortness of breath is typically developing on exertion, and sputum production is sometime present. This is the stage where patients usually seek attention because it's affecting their life, it's affecting their daily activities. And stage 3 is considered severe, so that's greater shortness of breath, reduced exercise capacity. You aren't able to do all of your daily activities that you were going to do before. You're easily fatigued, and repeated exacerbations that have an impact on your quality of life. And then the last stage is stage 4, which is very severe. Severe airflow limitation, respiratory failure, which may lead to right heart failure. And then quality of life is noticeably impaired, and exacerbations actually may be life-threatening. All right, so this is just another chart for you, big on the charts this time, staging COPD. All right, so so this is non-pharmacological therapy. We'll just really go over this pretty quickly. For patient group A, it is essential for smoking cessation. So if they're early in their COPD course, smoking cessation is essential. Also, physical activity and getting vaccinations, because patients with COPD are at higher risk for flu as well as pneumonia. And in later stages, B, C, and D, all of those apply, as well as they are eligible for pulmonary rehabilitation. All right, so getting into the pharmacologic therapy. So patients in class A, their recommended or first choice would be a SAMA or a SABA PRN. Alternative would be a long-acting SAMA or LABA, or both a short-acting beta agonist or a SAMA. And other possible treatments could be theophylline if those fail. I won't go through all of these. We'll go through these a little more in detail in a minute. Next 5 minutes. Goals of therapy is to relieve symptoms, prevent disease progression. So you cannot reverse anything. So like, how we said, asthma is reversible, COPD not as much, but we do want to prevent the disease from progression. That we can do. We want to improve exercise tolerance and quality of life, improve health status, and to prevent those complications and those exacerbations and reduce mortality. All right, so going into the short-acting bronchodilators. So again, it's the albuterol, levoalbuterol, anticholinergics is the ipratropium as well as the combination ipratropium and albuterol. So same drugs, just used in a different way. SABAs have a shorter duration of action versus ipratropium. SABA's agent of choice is the rescue medication. It is used as maintenance therapy in COPD, but just as rescue in asthma. Ipratropium may be added. Ipratropium may be added when adequate response to SABA is not found. Anticholinergics do play a larger role in COPD and in asthma. So in asthma, not as much. The beta agonists are the main players there, where anticholinergics do play a larger role in COPD. All right, so the long-acting bronchodilators, we have them here for you. It's, again, a lot of familiar names from the asthma charts, just reapplied here. And the LABAs here. Okay, so one that we'll go over is alpha-motorol. It is a LABA, or the brand name is Brovana. It's relatively newer. Dose is 15 micrograms per every 2 milliliter. It's nebulized twice daily every 12 hours, morning and evening. Same adverse effect as the other LABAs, and it does carry that black box warning, but it may not apply to patients with COPD because it's used differently. All right, so indacaterol is an ultra-long-acting LABA, or Arcapta is the brand name. It's dosed only once daily. It's a DPI via capsules and a neo-inhaler. Same adverse effects. The other LABAs, won't repeat those. And then again, that black box warning, but again, with the dosing, it may not apply with COPD. All right, vilanterol is another ultra-long-acting LABA. It does come in combination products. So there's the Briolepta, which is in combination with fluticasone, or the Anarolepta, which is in combination with umeclinidium. Dose is just once daily. It's a DPI with capsules or blisters, and it does have the same adverse effects as the other LABAs. I did have a patient who was taking their blisters. They were on the Briolepta, and they were taking their blisters orally. And so it's just something I mention. I know if they have never been, I always ask, have you ever been on an inhaler before when I dispense medication? If they have, then I say, okay, you're all set. But if they haven't, then I will show them how to use it, because patients do get confused and they see those. Those do look like they're blister-packed pills, right? Those unit dose pills, especially some of it's Spiriva in particular, where patients should be counseled. You think it would be common knowledge, but not always is. All right, so and then that is a little chart for you too about the anticholinergics. So tiotropium, the uniclinidium, and the aclinidium. All right, we'll just go through Spiriva, and then I'll let you guys go. 159, perfect. So Spiriva, a long-acting anticholinergic. I'm sure you guys have seen this. It's one of the more common ones. Comes in both the HandiHaler and the Respimat. It's also in combination with tiotropium. And never mind that. Competitively and reversibly inhibits acetylcholine at the muscarinic 3 receptor in bronchial smooth muscle. So smooth muscle relaxation is bronchodilation. Often seen as the first line despite GOLD guidelines. Vagal tone appears to be the only reversible component of airflow limitation in COPD, so we can improve vagal tone. Dose for the HandiHaler is that 18 micrograms, 1 capsule daily. That's every 24 hours. That is the one that's covered by Mass Health. That's the one that we see in Worcester most commonly. and the Respimat, which is a little newer, as 2 inhalations, 5 micrograms each, once daily. And maximum effect is usually obtained in about a week. All right, I'll let you guys. 2 o'clock. There you go. Sorry, guys, got more than I thought I was going to do, but. Thank you. Too kind. Much too. 109 out of 120, not terrible. Do you want to finish? Totally up to you. The person. It's still 2, right? Yeah, right. Person's not here. Oh, he's outside. Okay, okay. And I will. It won't take any more time than necessary. Oh, I did want to mention real quick, guys. The Cystic Fibrosis Foundation is something that my pharmacy is really close with. We have a couple CF patients. I had never known anyone with CF. I never knew anything about the disease. I never knew anything about the drugs. And it really is a horrible, horrible disease that pretty much affects young people. It affects people our age. And the average lifespan is only about 40 now, even with modern medicine and a lot of recent developments. So really, the Cystic Fibrosis Foundation plays a major role in drug development, and pharmacists play a major role because these patients are so sick and they require so much care that it's necessary that pharmacists are. I'm particularly there for drug interactions because our patients are on so many. So I'm actually volunteering at the walk. It's on Sunday, May 12th. I'm going to send a big email to blast it out, so it'll be there. But I will be there as well as my whole pharmacy staff. Like I said, we're super involved. I had the opportunity to go to the CF dinner last month, and it was just super eye-opening. A bunch of people spoke. It was really great. There's going to be a bunch of patients there, and you don't have to stay the whole day. It's actually it's like 10 to 2. It's going to be a smaller walk. The Boston one is a lot bigger. I think that's next week. That's the last weekend in May. But this one's Sunday, May 20th. You don't have to stay the whole time, but I would love it if anybody came and helped us. We're going to have a big water tent. I think we're donating 400 cases of water. That's what we're doing. So yeah, if you could help me come and pass out water, I would really appreciate it. So. But I will email. I'll blast this out. I leave this on.
Oh, my turn. Sorry for saying
Apparently it's already being recorded. They told me not to touch it, so I guess they're just going to keep it rolling all day.
I've been longing for Tom's friendship for 2 years and 10 months. What are you doing? Margarita and
I'm not doing that free. I'm not. You only get to take it twice. My bad.
You're out.
Why would you waste your time?
I'm not paying. What is that?
Nothing.
What did you learn from school? About studying at the college.
Hope you looked up everything. I got my 5 points. I was also trying to I passed it. There was questions I was trying.
I was watching Shameless. I got 72. And trying to something that look at the clock.
Oh, yeah, well, that was the other thing. I got caught up in.
I got 60 questions left in 20 minutes.
Yeah, that was my.
So it's so fun.
I got caught.
I need to talk to more.
Should I just check and see if they're close?
Do you want me to?
My phone died because I finished watching it. Did you watch
That's what our mom said.
I don't even know.
Oh, it's
Yeah.
But if I don't know how to do it, it goes like 10 minutes. Oh, I can figure it out. Well, Tom had a cell phone. Or, you know, more people.
My mom has.
Thanks.
I'm pretty sure you took out funniest videos. So you guys are both heads out? Or? Tom was. Well, I'll see you go
What original?
Or, yeah.
From the beginning.
Sure follows that. Actually.
We all saw it, and she said that she doesn't know.
All right. I think I scheduled the time was between 2 to 4 for the pharmaceutical calculation review, and already past time, so we got to get started. I know you guys ended the previous session a little bit late, but anyway. So my plan here is I'm not going to go through those slides, because those for your job. You guys going to read through this during the meantime. So it's the other handout I give to you, and we're going to walk through some questions, So and we're going to, probably you need to take out your calculator and with paper and doing some calculations, in the classroom. And at the same time, I'm going to walk through the questions and help you guys understand how to solve the problems, Those are the things we're going to plan to do for the next 2 hours. And if you have no interest in doing that, you can exit the room right now, so you don't have to exit during the middle of the time, Just let you know. That's the case. Okay? So if you do stay in the room and I need your cooperation, just stay with me and be patient. We're going to work through things step by step. Okay. I guess probably this is not the last time you see the NABLAX blueprint, right? This just slide to show you, the calculation is really important. There's a lot of, weight in the calculation. And it's a basic, and I don't know because I don't grade it, but I heard of, the calculation question, the weight more than the other questions. That means if you miss the one question, maybe, you have more penalty for a calculation question compared to the other questions. So try to, improve your calculation to get it right, because most of the calculations that really are basic. Okay. And so I believe, from the Blackboard, you already have access to those questions, And those questions actually that come from the exam masters, So maybe you already see it, because previously did all those pre-NABLAX readiness exams, right? So you might see it and you might already worked on it, but maybe you could just do it again, if you want to do that, or if you can just stare at me, if you don't want to do it. All right. Here's the first question, something like, first I give you a question, and you can spend 2 or 3 minutes doing it, and then I'll explain afterwards, how we're doing this, how do we approach some questions like that. So for the first question, I'll give you 2 minutes or something. Let you do familiar with the question, read through it, and then solve it. And if you can give your answer, that'd be great. Okay, go ahead. If you I mean, this is our hardest question you can get. I don't know. I'll give you something like more than 2 minutes, maybe 3 or 4 minutes. This is whether anyone can get anything.
Use the multiples. Steakhouse.
So if someone come up with the answer, you can raise your hand and tell me the answer or something like that. And then I know one of you already did it or something. I can start talking about it.
1360.
What is that? 1360. 1360? No.
Where's it in the bag? Where's the lip and stuff?
1360? No.
Wait, what?
Okay. I guess I'll start talking about this question right now, okay? So I know why you probably get why it's 1360, right? So the thing is, why not 1760? So basically, right, here you can see the question is to ask a pharmacist to make an order of this solution, right? So this solution compose all those ingredients, right? So they include the amino acid, dextrose, sodium chloride, potassium chloride, and et cetera, right? So the make this solution and give to the patient, and you didn't know. So the question to ask is how many calories per day this patient will receive. Per day, this patient will receive. And if the flow rate of the TPN is 150 mL per hour, that means for this preparation, right? It's not just give the patient for the whole day, right? You probably get the 1360 just for this preparation only. But the thing is, how much this patient will receive for the whole day for this preparation. You know what I mean? So they're giving more than just one preparation. Maybe give 3 or 4 bags or something like that. So it's multiple bags of making. This is just based on one bag. So that's the thing, So first you need to calculate is how much of the solution, how much volume, right? I need to give it to the patient, right? Then afterwards, then you need how many bags I give to the patient, right?
3.6.
What?
Seating 3,600.
Okay. So let's go to the next slide. I'll give you the solution. We can go through. So in order to know how many bags to give to the patient, then we need to know how many volume give per day and how much volume is in that bag. One bag is how much volume, right? So there's some of them already give you the volume, but some of them didn't. Such as the amino acid, they have 500 mL, right? So the dextrose 500 mL added in there. And your sodium chloride will give you amount. Then you need to calculate how much your volume is. Sodium chloride solution is added, right? So we need 5 mL because the total total amount of sodium chloride is 20 milliequivalent divided by the concentration, give 5 mils. And also potassium chloride amount divided by the concentration, give to the volume. So we just tabulate all the components, each of them one by one, to calculate each of the component volume, right? Combine all of them together, right? So combine all of them together, then that's the bag. That's one bag. You added all the components together. That's the total volume, for one preparation for one bag. But that one bag is not just for the whole day. It's just one bag for that preparation. And how many bags we need for that patient? So we need okay. Here we did a calculation just for the 1360, right? Why somebody gave the 1360 because that just comes from the one bag. So that one bag, most of the calories come from the amino acid and come from the dextrose. So and you did that calculation, get this 1360, right? So that's per bag. But how many bags we needed? So we need to get to the patient something like, so based on the amount given to the patient, 150 meals per hour and 24 hours per day. So that's 3,600 meals. So then the volume divided by the number of bags, so 3.39 bags. We need to give the patient 3.39 bags. That's a factor. And that factor times the 1360, right? So then that is the final calories given to the patient in 24 hours. Okay? Is it clear? Any questions?
What about the fat?
There's no fat in this one.
What's that?
No fat. What's up with that?
He's giving you extraneous information.
You have a separate bag of fats, but he's giving you.
I could not hear you very clear. So what is your question?
You're fine. Everything's good.
I'm fine? Okay.
You're good.
All right. So everybody's fine?
Everything's great.
All right. So and I know some of them try to juggle the answer down, I will post this answer onto Blackboard, okay? So don't juggle. You'll be fine. You're covered, okay? But I do want you to cooperate with me. So before I give you the answer, I want you to work on it first to see how far you can go for one question, All right? At least you practice on and where is the place you missed it, something like that. All right? Let's go to the second questions. I'll give you another 2 minutes or 3 minutes. At the same time, if you actually get the answer, just tell me what you get. Anyone done calculation? Have answered now? That's right. So, I mean, this is the question. That's the easiest one you can get. Okay. Why is the easiest one you can get? I have all the numbers. I have the equations. All you just need to do is plug in the number to get the answer. Okay. So for this equation, because the already told you he provided the Harrison-Benedict equation, and it told you the equation and it told you all the information. Weight, height, and age. Right. You need to know what is the weight. Weight is by kilograms. The height is by centimeter. Age is by year. So and make sure you know the male and the female. Then you get the answer. And I'll go to the next slide. They give you all those some other information. Sometimes you need to filter out the information you don't need it. You need to determine what information needed. Don't get confused. There's a lot of more information than you needed to solve this problem. Sometimes you just have to filter out some of the information. Right? Height we need to convert. Always convert. Something like 6 foot 1 to the centimeters. Right? We need to do that. Everybody should know how to convert that. And also from pounds to kilograms, everybody should know how to do that. This is the basics. And afterward, you just plug in the information and get the answer. So it seems this is one type of questions, and this is the easiest one. But on the other hand, there's something more than just these basic questions, right? Sometimes they ask you for something like, not just the rest of metabolic energy, or the EE. They ask you something like a total daily expenditure, right? Something like TDE. So in that sense, you need to remember, times the stress factor, times the activity factor, something. Those two factors will tell you in the answer, in the questions. So you need to remember to add those two factors to calculate the TDE. And then sometimes, this slide. So why they give you something like this, sometimes, This screen just doesn't work at all. Sometimes the lipids, something like give you 30%. When you have the TDE, right? So ask you how much lipids needed for this patient, right? So need to use 30% of the total daily expenditure is the amount of lipid you need based on that calculate calories. And also sometimes calculate the carbohydrate for the rest of the carbohydrate needed for the calories needed, and also calculate the amount of amino acid needed after subtracting that, all those information. So I guess, for example, here I will ask, right? So we have this information. You have this value, right? So then I'll tell you the stress factor for this patient is 1.2. So we say the stress factor is 1.2 and the activity factor is 1.2, right? I cannot write. So stress factor 1.2 and activity factor 1.2. And for this patient, we make the total nutrition preparation for this patient, right? So based on the 30% of the lipid value for this patient, right? So how much lipids we need to give to the patient? So anyone do that calculation, we want the 30% of lipids for that preparation. How much of the lipids would be, in terms of for this patient, we give to the patient. How much lipids per day for this patient? Right, that's just one step further, because they told you 30% of lipids, right? So then they tell you the stress factor and the activity factor.
91.5.
So that's should be pretty straightforward, right? So basically, you just calculate TDE based on the 1906 times 1.2 times 1.2, right? Get the answer. Then times the 30%. That's how much of the calories for the lipids, right? Then divided by 9. Then you get the amount of the lipids you needed for that patient, okay? So that's just some extension for this kind of questions, okay? All right. Any questions for this one? All right. So we're going to the next one, all right? Okay. Take a look at this one. If anyone have the answer, just let me know. This answer? Yeah, 1 to 25. Very good. So this is the easy one, 40 milligram per meal, just 40 milligram versus 1 meal. Then normalize the grams, and then do 400, you do 4 grams to 100 meals. And always, when you have the ratio strength, make sure the first one is the 1. The first number is 1, and what is the rest number, just make sure that's the case for ratio strength. 1 to 25. Any questions? All right, no question. Okay, about this one. What is the answer?
Yeah.
That's right, 180.
Okay, so just one.
Okay, basically this is the thing you need to remember, there's just a conversion between the millimoles to milli equivalent, okay? So here's the equation you need to remember, So millimoles is the number of the moleculars, or number of the particles, right? Milli equivalent is number of the total charges, right? Just know that. So millimoles times the valence equal to milli equivalent. For example, if it's a potassium, right, it's one charge. So one molecule is one charge. But if it's calcium, one molecule is two charges. So one molecule times 2 charge is the 2 milli equivalent. Okay? Just got that one right. All right? So on the other hand, if you want to calculate what is from millimoles, from milli equivalent to millimoles, right? So just milli equivalent divided by the valence. So just get those right, okay? The conversion between millimoles and milli equivalent charge and the particle numbers. So the number of millimoles for magnesium, in 100 mils, right? Because we know the magnesium we have is 1.5 milli equivalent, right? So the charge for the magnesium ions is 2. So divided by 2, so that means the magnesium ions is 0.75 millimoles, right? Milli equivalent divided by 2 by the charge is the millimoles. So then, since we know the millimoles, then we just use the millimoles times the molecular weight. So the molecular weight is what for the magnesium ions? It's 24 milligrams per millimoles, right? Right. So then you know the weight of the magnesium in milligrams. So from the millimoles go to milligrams. That's easy. So you needed a middle step, from milli equivalent to milligrams. So now you know the weight is 18 milligrams, right? So the concentration of magnesium ion would be just 18 milligrams per 100 mils, right? Because the 1.5 milli equivalent in 100 mils, so it's 18 milligrams in 100 mils. So then enlarged to the 1 liter. How much is in 1 liter? So that obviously 180 milligrams in 1 liter, right? 10 times bigger. So that's the answer. Any questions for this one? Yeah, someone else? No question? All right.
Yeah, I thought it was grams per millimole.
You asking me a question or?
Just give us 1 second.
I'll give you 1 second. All right.
Yeah, thank you.
All right. Yeah, just remember this basic equation of conversion between millimoles and milli equivalent. So very useful. No matter what, always convert to millimoles. Done?
Yes, thank you.
Okay. Next one. Okay. Another 2 minutes for you guys.
Just looked at it. You have to know that. There's certain ones you
Someone has answer? Okay. All right. Okay, for this question, basically it's a dosing, right? This is dosing to the patient based on the ideal body weight. So obviously, since it's ideal body weight, you need to know the equation for ideal body weight. So that's the equation you have to know, and this equation won't give to you. You have to remember it. And it's easy, right? For male, ideal body weight is 110 pounds plus every inch about 5 foot, times 5 pounds. That's for male. And for female, it's just 100 pounds and every inch about 5 foot times 5 pounds. Okay? So those are the two equations you need to know. Then convert the number, the answer you got to kilograms. Convert that to kilograms. So for this patient, right, it's a female. So we use the equation, get 135 pounds, that's 61.4 kilograms. And for this, as you can see here, the patient body weight here is 135 pounds, right? The ideal body weight is lower than the actual body weight, which is here 157 pounds here. So you can use the ideal body weight. However, if this number is not 157, if it's 127, which number are you going to use dosing this patient? If it's 127, if the patient's actual body weight is 127 pounds.
Depends on the drug.
What's that?
Whatever they tell you to, like if they specify.
No. So the actual body weight, if it's lower than ideal body weight, you use the actual body weight. Okay? So that's some kind of, if really want to make it more difficult for you guys, so don't use 135, use 127, because that's actually the body weight the patient have is lower than ideal body weight. You use the actual body weight because this patient is lame and underweight, right? You use.
So even if it's like a calculation.
Yes, you say it's dosing based on ideal body weight. If the ideal body weight is, the actual body weight is lower than ideal body weight, use the actual body weight. Okay? All right? That makes sense because the purpose for ideal body weight is kind of discount any extra body weight from the fat tissue, right? If the patient, the patient by itself have even less of the mass, than the ideal body weight. Obviously, you need a dose based on his actual body weight. Okay? That's something you need to pay attention to. Okay? So any question regarding that? Okay, it's clear for you guys. Okay, then based on the ideal body weight, right, then you just calculate the maintenance dose 2 kilogram per hour times the 16.1, and then the maintenance dose over 48 hours is 5.89 grams. So that's the easy part. So here, just to let you know, because I don't exactly have the answer for this question, but I just give you guys some of my understanding. Here, just calculate the maintenance dose, right? So maybe this is the right answer. But here, told you how much of the drug in the patient receive over the 48 hours. Do we need to include the loading dose too? The first dose? Do we need to include that too? Because you have the first dose, right?
Yeah,
So in that case, you need to calculate the loading dose, right? The first dose given to the patient. So the 5 milligram times the ideal body weight, the 0.3 grams. So then the total dose would be the maintenance loading dose plus the maintenance dose over the 48 hours. So that's 6.1219 grams. Okay? All right. Seems here, I think it's, in my understanding, this is asking for the total dose, right? How much drug will for the 48 period. This should include the loading dose, not just the maintenance dose alone. Okay, any questions for this? Yes, what is the question?
I thought when you give the loading dose, you have to wait for like 30 minutes to an hour to give the maintenance dose.
I really cannot hear you.
So when you give the loading dose of a drug, don't you have to wait for like a certain amount of time to give the maintenance dose? So,
no, you don't. Because the loading dose is the injection first. The maintenance dose is the infusion. Right? right? The maintenance dose is the IV infusion. You just hold for the rest of the time. That's the maintenance dose. So basically, after the IV, after the injection, you just starting IV right away. All right. Okay, that was this one. Then we're doing the next one. Number 6. Now I have an answer. Yes. So this is something related to the like a compounding, right? Related to compounding. How much give you a formula? Then you have a batch. I mean, make a preparation in 30 grams. How much of the ingredient you have to use it, right? So this is like something like compounding calculation. Okay. So basically, first you need to know is the percentage. Basically the column in that preparation. What the percentage concentration in terms of. So you get that. Then after that, then you just the amount, the preparation you make times the concentration of that ingredient. Then you get the amount you needed for that particular ingredient. Okay, this is an easy one. How about this one? Number 7.
You would think this is coffee. Yeah.
Someone have answer? Yes, yes. So basically, this type of question is basically, for drug to give to the patient, right? So they told you the amount of the drug, what is it? But actually, the available drug is a different form. The available drug is a different form, or they express a different form. That's what it is, right? The drug given to the patient is fentanyl citrate, but the concentration we know is 15 microgram per ml, but it's in fentanyl. So the fentanyl citrate, fentanyl, what's the connection between these two? Is the number of molecules, right? Moles. So that means we need to convert those to moles. Then we can do the calculation, So basically that's, the dose of fentanyl is 100 micrograms. So the 100 micrograms and divided by the molecular weight, then we get the number of moles for the fentanyl citrate, right? So number of moles of fentanyl citrate is equivalent to the number of moles for the fentanyl, the base. So then we know that's how much for the fentanyl base we needed. Then convert that to the concentration, to the weight of the fentanyl base, right? Just times the molecular weight of the fentanyl base. Then afterwards, then we divide that by the concentration available for the fentanyl base, right? So that's just how you get the volume you needed for the fentanyl citrate, It's just something like converting to the molecular based on the moles, and then from one form to another form, the weight. Divided by molecular weight, then times the molecular weight of other form, so you just get the answer. Any questions? Okay. All right, no more question. We'll move on to the next one. I know this one you had it before, in the exam master. Right? Someone asked me the question, how do you do this one? Someone have an answer? Yes. Yes. Okay, so this is an easy one. The only thing you need to do is have to filter out some of the information you don't need it. Okay, so you can see this. There's a lot of information, but basically those whole table is not needed, right? So basically you have a formula here, and the only thing you need is here, right? The potassium chloride. That's what is asked, right? And also use that concentration, and you need to make 2.5 liters. So that means based on this information, you need to know how much potassium chloride you needed, right? Then based on the potassium chloride needed and based on the concentration available, then you can know how much potassium chloride in that concentrated solution, you need it in volume. So there's a lot of some set information. You need to know how to choose the information you need. So here is right, the potassium chloride needed. So 100, because you're making 150 millimoles per liter solution, and you're going to make 2.5 liters. So that's how much of the potassium chloride needed, right? 375 millimoles, right? So then, because the solution they give to you, they give it in the formula is in millimoles per liter, but the concentration, the stock solution they give you is a milliequivalent per mil, right? So in that case, you need to convert. There's a conversion between milliequivalent and millimoles. Remember that. So we have millimoles. So what is the milliequivalent for this 375 millimoles, right? Because potassium chloride, the potassium is +1. So the valence is 1. So milliequivalent and millimoles are equivalent to each other. The number is the same. So potassium chloride in milliequivalent will be just 375 millimoles times 1 to 375 milliequivalent, right? So there's no tricky part, remember the conversion between milliequivalent and millimoles. So the volume available, right? The stock solution available to make the injections is 500 milliequivalent to 250 mils. That's the concentrated solution we have. So just the amount we want, the amount of the drug or the potassium chloride here, and divide by the concentration, of the stock solution. So then we get the volume we needed, right? Any question with this one? Okay. So don't get scared, with some kind of question with plenty of numbers. Choose the number you needed. All right, we're moving to the next one. Number 9. So this is to make a isotonic solution, with some drug in there and give you the equivalent value. So tell you how much of sodium chloride is added in there to make this eye drop solution isotonic, right? Yeah, take your time to do this calculation. This is something probably most of the time you will see one of these questions. So if you get the answer, just let me know. We can start talking. Yes. Okay. So basically for this type of kind of question, right? So there's two kind of information you need to know. So what is the E value, right? So E value means so equivalent to the sodium chloride. So the drug X, right, they have E value of 0.92. What that means is 0.9. So 1 grams of the drug is equivalent to 0.9192 grams of the sodium chloride. That's 1 gram of drug equivalent to 0.92 grams of sodium chloride, okay? Okay, here's another information you need to know is 0.9% of sodium chloride solution is isotonic solution. That's the information you need to know. 0.9% sodium chloride is isotonic solution. So you need that. So first, you need to assume for make a 30 mL of solution without any drugs, right? The drug don't contribute anything to do the tonicity. How much of sodium chloride you needed? How much sodium chloride needed for the 30 mL of the solution? For the sodium chloride you needed without the contribution from any other drugs, right? So because 0.9% is 0.9 grams of sodium chloride in 100 mL of solution, so that's 0.9% is isotonic. So the solution we're going to make is 30 mL. So then we times together we find out. So if there's no drug contribution for the tonicity, the 0.27 grams of sodium chloride will make it isotonic. And after we get that number, then we calculate how much of the contribution from the drugs, right? Then subtract that from the 0.27. Whatever left is what we needed, added for the sodium chloride. Okay? So for the drug X, we know the concentration for this solution is 0.004%, right? So 0.004% is right this 0.004 grams per 100 mL. That's the concentration. Then times the 30 mL, we got this 0.0012 grams. Then the equivalent of the drug X to sodium chloride is just the amount, right? Times the 0.92, right? Remember that. So that's equivalent to the amount of the sodium chloride. Same thing you do that with the drug Y, the concentration of the drug Y times the 30 mL, that's how much of the drug Y in that solution. And then the solution times 0.36 is E value, then get the contribution the equivalent to how much of the sodium chloride. So then you just subtract that from the 0.27, right? So whatever the number left, the amount left, the sodium chloride is you needed to add it in the solution to make it isotonic, right? Any questions? These are some of the basic calculation, and you have to master, and it's most likely you will be tested. Okay. No more question, huh? So I just added a little bit more to make this question a little bit harder for you guys, okay? So change. So how much, instead of saying sodium chloride, sometimes, when we make eye drops, they don't use sodium chloride. Let's use boric acid. Let's say, how much boric acid? I cannot write anything with this. So, boric acid, okay? How much boric acid, with how much instead of say sodium chloride, we cross this up. How much boric acid you need in milligrams to make this solution below isotonic? They will tell you the boric acid have a E value of 0.52, right? 0.52. So what is the boric acid? How much boric acid you need to make that solution isotonic? Guys, any idea? So we're not adding sodium chloride, we're adding boric acid.
Yeah, that's definitely.
So instead of adding the sodium chloride, right, you can add the boric acid to make it isotonic also. And boric acid is also one of the components that can use for eye drops. What is the amount of boric acid added to make it isotonic? And they give you a value of 0.52 for the boric acid. What is the value? What is it? Someone give me an answer? No answer? Okay. Someone have answered? What is that?
267 milligrams.
Yeah, that's right. That's right. It's easy, right? So we're almost done, with the step here. So even though it's after boric acid, you still do this calculation from the top to bottom until you get this step, right? Until you get to the last step, how much sodium chloride you needed to make it isotonic. Then switch sodium chloride to boric acid. You understand what I mean? Instead of the sodium chloride, we added boric acid. Just calculate how much sodium chloride here equivalent to the boric acid. By use that number divided by E-value, divided by the E-value over the boric acid. Then you get the amount for the boric acid amount, right? So after this divided by that, you can get something like a 0.2679 grams of boric acid. Okay, so understand that part? So, any questions? Okay. Alrighty. If no more question, we'll go to the next one. Okay, this one. This. Anyone have answer yet? How much?
They're doing it by total.
What is the answer?
1477. That's her total.
No.
House and then 30%.
Who else have answer? That's right. 213 is the right one. So I guess you get the answer because you're confused a little bit, So you see, there's something like this, right? Harris-Benedict equation that you're doing all those calculations with that. So, but here, so he's asking about how many kilocalories provided from a amino acid solution, right? 7%. But they didn't tell you how much of the amino acid you needed, right? The 7%, how much of that. So the main point is here, you need to determine how much protein or amino acid you need to give to the patient, right? So how much amino acid to give to the patient is based on the body weight, right? 0.75 grams per kilograms body weight for the patient, right? So it doesn't matter how much of the calories the patient needed. The patient only needs 0.75 grams per kilograms of body weight. So based on the body weight, calculate that the proteins needed. Then you calculate how many calories from the proteins, right? So here, you got the body weight, and the protein needed is just 0.75 grams per kilogram times 74.9. That's a body weight, and then calories from the proteins, right? I know this equation. This question gives you a stress factor, right? The stress factor is for calculate the calories. It's not for calculate the proteins. The proteins don't need to normalize for the stress factor, okay? But the proteins may be varied depending on the disease stage, something. But that information usually give you by the questions. So, okay. Any questions for this one? No? Okay, good. This is a easy one. Okay, this one, number 11. Yes. Okay, so this is another type of kind of question, and usually will show up. So for the allegation method, right? So you need to know how to use the allegation method to do the calculation. Basically, you have two of the starting point, right? One is 2.5% hydrocortisone, another one is 0.75% hydrocortisone, and you know what is the target concentration, right? After mixing, what is the concentration you needed to achieve? That's 1%. And you use 2.5% minus the 1%, you get the answer is 1.5%. And also when you have some 0.75%, minus the 1%, you get the 0.25%. So here is these two numbers, the ratio of these two numbers. That's what is important. The ratio of these two numbers, okay? There's nothing to do with really meaning 0.25%, 1.5% is actually the ratio. So that ratio determines how much percentage, what the ratio of these two components, the ratio of those two components. So 0.25% of the cream versus 0.75% of cream, the ratio of those two, the amount of those two is 0.25% versus 0.5%. Okay, so the top one still top one, the ratio. Bottom one still the bottom one. Okay, that's why this one is worth use this number. This one is here. So the high concentration versus low concentration have a ratio 1:6, right? So when you based on that ratio, you do the calculation. So then how much amount of the high concentration chlorine versus the 250 grams of the low concentration chlorine that have a ratio 1:6. Then you get the amount needed for the high concentration. Any question with this one? So this is one of the questions you have to master, okay? The alligation method, you should know it. Okay. I think right now we're half through, and I'm going to let you guys take a 5 minutes break. Okay, if you would like to.
Oh, it's when you have it. So it's so he was saying the total volume.
How much of
I know, but if the question was knowing that the total needs to be 250.
or total needs to be 6. So now I got 1.75 parts. And then you calculate that as the goes across 0.25, that's the weight times the 30 grams. That's 0.25. So you divide it by the ratio. Here's the ratio. Yeah. 5, 6. No, there's 3. So that is like yeah. Yeah, so you need up to 6. So you're just how much you get?
No.
I know. Yourself. Ready?
Okay. Look like a new battery get more power. All right, settle down. We're going to go to the next question. Okay, here's a question. Talk about the, give you a bunch of information and told you how to estimate the patient the creatinine clearance. Use the Cockcroft equation, right? So obviously you need to remember what is the Cockcroft equation and do an estimate about the patient creatinine clearance rate. And why don't you handle this? Tell me what you got. What's that? Okay, 57.95. Yeah, you got one. Okay, let's talk about this. Someone gets an answer and we're going to talk about it. So right or wrong, we'll tell. So for making the Cockcroft equation, here's some of the information needed. First, you need to pay attention whether this patient is a male or female. That's important, right? And you need to know the height and the weight, right? And also from this blood panel, you need to know where is the creatinine clearance. The serum creatinine level. So those are the information needed, right? And then, so you need to know there's a creatinine clearance, right? The equation for the Cockcroft equation, here's the weight, right? 140 minus age times the weight divided by 72 times the creatinine clearance concentration. So, and because this is for male, right? That's a trap, okay? You need to remember for a female, don't forget about times to 0.85. That's the thing, don't forget that part. That's always a trap there. So now we talk about, the weight. So there's 3 types of weight, right? One type of weight is the actual body weight, ABW, actual body weight. Another is the ideal body weight. And another one is the adjusted body weight, okay? There's all 3 of them. Actual body weight, ideal body weight, or... So what kind of condition you use the actual body weight to calculate creatinine clearance? That's when the actual body weight is lower than the ideal body weight. You use the actual body weight to do the calculation. So, right? When your actual body weight is smaller than ideal body weight, you use the actual body weight. So for this patient, right, we have know the actual body weight. So 140 minus 76 times 79 kilograms, that's the actual body weight. And then divided by 72 times the 1.03, that's the creatinine clearance, times 0.85. That's because it's female. So you got a 57.95. So that's a creatinine clearance rate. Based on the actual body weight, you got a number, right? So for this patient, so what is the ideal body weight for this patient, right? So this patient ideal body weight, based on the calculation, find out 100 pounds and 5 pounds, inches above 5 pounds. and 120 pounds. So the ideal body weight is 54 kilograms, right? So obviously, probably need to use the ideal body weight to do the calculation. So when we do that again, so we get something like creatinine clearance rate for something like a 39.98, right? 40 mil. So those are two of the body weight. They use two different values, right? One is close to 60, one is close to 40. There's a big discrepancy. So use the actual body weight. Most of the time for overweight patient, you kind of exaggerate the creatinine clearance rate, and use the ideal body weight. You actually could underestimate the creatinine clearance rate. So the best way is actually use something called the adjusted body weight, especially for those with obese or overweight. For example, for this patient, right, the BMI, body mass index, you need to know this equation too. So these are actual body weight divided by the height of this patient, 1.62 meter. So it's 30, right? When it's 30, that means it's already borderline to the obese, right? 30 to 40 is obese, and about 40 is extreme obese, right? So for this patient, is obese condition, so you use the actual body weight. Obviously, it's not a good way to go. And use ideal body weight, you could actually underestimate the patient creatinine clearance rate. So the best way is use some kind of called the adjusted body weight for those obese or overweight patients. For those patients, use the adjusted body weight. So adjusted body weight is ideal body weight times the difference between the actual body weight and the ideal body weight times 3.4, the factor. So that's called adjusted body weight. Okay, so use the adjusted body weight, and then you can get 64.3 kilograms. That's something like adjusted body weight. Use that number to do a calculation. You find out creatinine clearance rate 47. So this is more closely related to the actual person's creatinine clearance rate. Use the adjusted body weight, especially for those overweight patients. Okay? Any questions with this one? No? Okay. We're going to move on to the next one, okay? All right. What about this one? So what is the infusion rate in terms of the drops per minute? What is it?
100.
100? Any other answer? 102, yeah, 102 is the right answer. So 100 is because, so the normal saline, right, is 100 mils. But then you have added this drug in there into normal saline, then you have extra volume, So you need to calculate how much extra volume added in the IV bag, right? So in that case, that's just how, the drug is 50 milligrams, and the concentration for this drug is 25 milligrams per meal. So you added 2 meals of that solution in there. So then the final final volume is 100 mils of normal saline plus the 2 mil of the drug solution. So total is 102 mils. So then after the total volume, then calculate the total number of drops, right? Total number of drops times the drops per meal, you get 2040 drops. Then divided by the infusion span of the minutes, right? So you get drops per minute. Okay, any questions? No? All right, we're going to move to the next one. 14. Any answers? What's that? Yes, that's right. That's right. So this is an easy one, right? These are compounding questions, So basically, I know the concentration for this triamcinolone acetonide in this vehicle, which is a cream. And then you need 60 grams of that, and then you just, and the stock solution to provide the acetonide is 40 milligram per ml solution. So basically, that's just how you need to do is first calculate how much of that triamcinolone acetonide you need, right? By use the concentration, 0.25 grams per 100 ml, per 100 grams, and times the amount you prepare. So the amount of drug you get, and the amount of drug divided by the concentration of the stock solution. Then you get 0.375 mils. So those are the easy questions. And for easy questions, you should get the answer. You usually get the points, Okay. Let's go to the next one. 15. What's the answer? Someone have it?
10 days.
For the whole 10 days, is what we're asking, right?
Well, you have to read the questions. You have to read the question, right? Calculating appropriate dose in volume. Appropriate dose in volume. Right? You don't give the whole 10 days once, right? Dose in volume, right?
Give them a 10-day prescription.
What is the dosing volume for this patient? A dosing volume is called unit dose. It's not the whole bottle. That's not dosing volume.
Okay.
That's how much amount of drug gives to the patient. Right? Yeah, 4 is the answer. Okay, basically for this one, you just need to know the concentration here is available, right? And then the dosing is based on 40 milligram per kilograms every 24 hours. So that's what you need to know. What? Why I get it down? So you need to know how much. What's wrong with this? So you need to know how much is that the drug is in every dose, right? So calculate the body weight and then based on that determine the amount of the drug dose per dose. This is 40 milligrams per kilogram times the body weight, get the milligrams per dose, and divide by the concentration. That's the dose volume, right? So don't confuse with the total amount. Since most of pharmacy probably will give you more than just the exact amount you needed, right? For the 10 days, the supply. Okay, next one. So. Someone have answer? 275? 266? I got 279. 279 is my answer. Maybe you got something like that. The ounce is not exactly 30. You got 228.3. Are you using that one? Okay. So basically, for 100 meals, right, you need to calculate what the contribution from the proteins, what the contribution from the fat, and pay attention to what is the carbohydrate, is 4 kilocalories per gram, not 3.4. So there's a difference between the enteral and the parental nutrition, use the factor of 4. So then you can calculate how much is for the 100 meals, right? So you need to know what is 8 ounces. 8 ounces, I use the 240, so 30 meals. So if you use something like a 29.5, then that's fine. That's fine. So in the ballpark in there, that's what I got. Okay, any questions? All right, just remember this, there's 4 kilocalories in this for enteral nutrition. It's different than 3.4. Okay, this one. What is the answer? Yes, that's an easy one, right? So 0.2 milligrams per kilograms, and that times the body weight, 12 milligrams per day, 6 milligrams per dose, right? So there's no question about this one. Those are easy ones. You should get it. Okay, how about this one? What you got? What you got, someone? Anyone got an answer?
$1.637.
Yes. Isn't it a simple question? But make it look so complicated, right? But this is really simple, you know. So they are making this solution, right? Need to make 5 ml of that solution. You need to dissolve this drug, right? They say that in order to dissolve this drug, you need to use at least 1/3 of the solution volume. Of the buffer solution, 1/3 of the solution volume. What is the minimum of 1/3? The minimum volume of the buffer is what? 1/3 of the 5 ml? Yeah, sometimes they just trigger you, make this look so complicated, huh? They provide you a lot of information and they usually don't need it. Okay. 19. Anyone have answer? 92. Yes, that's right. So you got to know this. You know, this type of question will be show up in your NAPLAX exam, and the most creatinine clearance is actually based on something like this. You know, so calculate creatinine clearance and choose the different options. You know, based on the creatinine clearance level. So basically, this is a female. You know, so they always give you a female because they don't want you to forget about. Don't let you forget about the 0.85, you know. So that's the value. And here, so there's a two actual body weight is 145, and the ideal body weight is 135. Ideal body weight is smaller than actual body weight, so you use the ideal body weight to do the calculation. And for here, it doesn't matter because the creatinine clearance rate is so high. So the creatinine clearance rate is so high for this patient. So, and based on that value, you can just go to that slide and find out from the previous slide where is that. Is because they're larger than 60 mL per minute, so use Q8 every 8 hours, and the dose regimen is still where is that? Where is that value? Where is that value? Where is that? Here. 10 milligram per, oh here, 1.5 milligram per kilogram is ideal body weight. So then you 1.5 milligram per kilogram times the ideal body weight on Q8. All right. So no question with this one, right? Any questions? No. Number 20. What is it? 24? Who else has the answer? Any other answers except 24? 24 is the right answer? Is it? What's that? What you got? 24. So everybody agrees 24? 25. 25 is the right answer. 25, right? So why 25? Not 24. So the reason for that is because, here, the answer is here. Assume all those are prepared in the morning, and the expiration date is 24 hours. That means you cannot just make one big batch and give it to 5 days. Every day you need to make a batch for that day, and the next day you need to make a new batch. So in that case, it's not 24. So gentamicin per dose is 1.7 milligram per kilogram times the body weight. And then that's Q8, right? So then 3 doses per day is at 385 milligrams. So that's the number of milligrams and the number of the drug you need divided by the amount provided from each vial. That means how many vials are needed per day to make that batch. To find out it's 4.78 vials, right? That was for making it in 1 day. You need 5 vials. You cannot 4.78, because after you use the 4.78, the rest you have to discard. You cannot use it anymore. So that's 5 vials for make 1 day. You have 5 days, and you can make 5 batches. So that's 25 vials. Any question with this one? Okay, because expiration is 24 hours. Every day you need to make a new batch for the patient. Okay, let's move on to the next one. Someone get the answer? Yes. 68 is the right answer. So this is an easy question, right? So it's straightforward. There's no tricky part at all. So the total number of the sodium consumed, right? Just 2 servings. So that's the amount of sodium you got. And the minimum also of the sodium you got is just divided by molecular weight of the sodium, right? 68 millimoles. All right? Okay, let's move to the last of today's question. And so the last question, go ahead, give it a try. And you know, this is from the new textbook, and before we guys teach you guys with this type kind of questions before. See whether you can get this way. Someone have answer yet? A, B, C, D, E, which one? I saw this is easy one. You just choose A, B, C, D, E. C, huh? C. Who else? Everybody C?
I got E.
You got E. Okay. More E's than C?
Yeah.
Okay. E is the right answer. E is the right answer. Did you choose randomly chose C? Okay, let's talk about this one, okay? Don't worry, we'll talk about it just because maybe for some of you, this is something new, okay? All right, for this type of question, right, they call it equal analgesic dose, right? So basically the list here, we have here the drug we have is the fentanyl, right? So fentanyl is a parenteral injection, right? So even though this parenteral is equivalent to hydromorphine here and also equivalent to the oral here. So in that same category. So the key here is you don't just add one single dose. You need to add the whole daily dose, how much of the fentanyl is. Then equivalent to how much of the daily dose for the hydromorphine, because the drug here is hydromorphine, right? So 0.1 milligram is equivalent to 7.5 milligrams. But how many daily dose of the fentanyl we have here? Daily fentanyl is 0.5 mils, right? Times 50 micrograms per mil, every 2 hours. So 0.5 mil times 50 micrograms per mil times 12, because for a day is 24 hours. Every 2 hours, that means you give it 12 times, right? I'll give it 12 times, so that's 0.3 milligrams of fentanyl to give to the patient. So 0.1 milligrams of fentanyl is equivalent to 7.5 milligrams of hydromorphine, right? So that's from the dosing table. So, and the 0.3 milligrams of fentanyl is equivalent to 22.5 milligrams of hydromorphine. So that's daily dose for fentanyl, and this is daily dose for hydromorphine, 22.5 milligrams per day oral hydromorphine, right? So then, because the tablet is available every 6 hours, Q6, right? So that means give 4 times a day. So the amount is 22.5 milligrams divided by 4. That's 5.6 milligrams Q6 hours. So the closest tablet available is 6 milligrams per tablet, right? For Q6. So that's the answer. Okay, any questions? What's that? Don't take it by 25%. Where did the 25% come from? So you do based on dosing table that you call analgesic, you know. So this table tells you it's 0.1 milligrams equivalent to 7.5. So that's already converted right there. So yes. What's that? Let me go back. Okay, let me go back to the next slide. So, but 0.5 mils, right? 50 times 12, and then times 0.5. That's 300. So you give the 0.5 mils, the concentration is 50 microgram per mil, but you only give 0.5 mils to the patient. Any other questions? All right, we're done with this review then. So what I can say is good luck with your border exam. Right? Do your best. You know, we need you to do your best. You know, we need to improve the lab passing rate.
Yeah.
All right, good luck. Okay.
All the math at MCP.
I post this with the answer on the blackboard. Okay, if you are interested, you can go there and get it.
Thank you.
All right. Bye.
That was a crazy laugh, John.
Oh, no.